Good afternoon to all. We have lined up the three interesting clinical scenarios. Dr. G. Uma is Associate Professor of what is that? Vinayaka Institute of Medical Sciences and Research, Pattu. And professional achievements are AHS certified BLS and ACLS instructor at KIMS and visiting faculty at AHA BLS instructor. So, over to you, madam.
Introduction. At the outset, I would like to thank the organizers for giving me this opportunity, and I bring wishes from our department, Vinayaka Institute of Medical Sciences, and on to the topic. After listening to such wonderful lecture from the morning on pediatric and cardiac anesthesia, now we are on to endocrine. Let's see what I have to offer. So the topic is huge retrosternal goiter patient coming for thyroidectomy. So the first thing we should remember is, as anesthesiologists, the era of saying this patient is not fit or we cannot give anesthesia, all that is gone. It's all now optimizing and taking every patient for that particular surgery and giving a good outcome. So it always seems impossible until it is done. Please remember this. This is for the postgraduates to remember. It's all planning how we give anesthesia and how we are going to give a good outcome. So what are retrosternal goiters? It's defined in many ways, but widely accepted is that 50% of the enlarged thyroid gland has to be below the suprasternal notch. And if you can see from the ENT textbooks, like they have, the goiter is graded according to the position in the mediastinum. But for us, as the mediastinum is a confined space, the enlarged gland causes pressure symptoms necessitating the goiter to be removed. That's when the patient comes, when there are pressure symptoms. So what are the problems which we are going to face? What are the things which are going to be challenging? It's a difficult intubation. About the blood loss we have to think about, long duration of surgery. Cardiovascular compromise can happen during an perioperative period. The potential risk for total obstruction of the distal trachea after induction, please remember this, and risk for tracheomalacia after extubation. So how will you go about seeing this patient? General clinical and all system examination has to be obviously done. Examination of the swelling. So we have to see the size and whether we are able to feel lower border of the swelling. Of course, here there is an extension we may not be able to feel. And in the airway examination, whether we have any difficulty in mask ventilation. Of course, there is going to be difficulty in intubation, but apart from that, other difficulties and all the regular airway examination has to be done, and always document the plan of intubation. So what are all the investigations they'll do generally? If already there is a biopsy done, please remember a malignant tumor, it may be infiltrating the airway. It's going to cause a tumor collapse on induction, more airway obstruction and hypoxia. Please remember this. But in a benign goiter, if it is causing external compression, the cervical part of it maybe we'll be able to lift it at the time of endotracheal intubation. That may help us in passing the tube down the trachea. And of course, the thyroid function test to know the hypo or hyperthyroid level so that we can optimize the patient, and the regular investigations, and always evaluation by cardiologist, pulmonologist and ENT surgeon, because the ECG, echo and pulmonary function test will help us to know their clinical status. At the same time, by pulmonologists, when they see the PFT, we are going to know about what is the obstruction, airway obstruction, and what are the problems the patient is facing, so that we can optimize him. And indirect laryngoscopy always to assess the vocal cord movements, and we have to document this preoperatively, because preoperatively itself there may be a vocal cord palsy, so it's better to do it. And bronchoscopy, here one thing is, this is going to help in such patients who have a huge retrosternal goiter, because it will show us the dynamic obstruction and which is the narrowest part of the trachea. We have to really know it, because we might be able to put the tube and then the tube does not go below the vocal cord, it will go, but then beyond that, at the narrow part, it may not go. So you have to keep smaller tubes ready. Probably you have to tell the ENT surgeon he might have to do a dialysis and laryngoscopy and pass the tube. In spite of you doing a fiber optic scope, you may not be able to intubate. And X-ray chest to assess the mediastinal mass size and compression. X-ray neck, AP and lateral is very, very important to see the tracheal deviation and compression, how much it is compressed. Of course, we have ultrasound of airway now, we all are getting adapted to it, and we all know it. So it will show us how much the distortion is happening in the trachea and what is the narrowest part. So we will be ready with the armamentarium. The CT and contrast enhanced CT and MRI all these help us in assessing the tracheal deviation, which is the narrowest part of the trachea, and how much is the swelling into the thoracic cavity. So whether can we expect a CV collapse at induction, and we can obviously involve the cardiothoracic surgeon and keep the cardiopulmonary bypass ready. And SpO2 in room air, both in supine and sitting position, this is very important, because some of these patients, when they come with obstructive symptoms, they may, when they are lying down, they may be going in for stridor. So we have to observe this, and please make sure that you document the SpO2 in room air and in both supine and sitting position. So here are some of the pictures that I have put. I don't have a pointer, and I think, but you'll be able to make out. The first one is showing how was the trachea seen. In the second one, a huge swelling is seen where there is some amount of deviation shown, and in the anterior view where it is marked, you can see the compression and the deviation. In the anterior you can see the deviation and the compression in the lateral view. In all these CT and contrainfant CT studies, definitely they will show here the first one, comparatively it is showing on the X-ray how much deviation of the trachea is there, you can see, and how much it is narrowed, that is shown on the CECT. The same way MRI also, the lower picture, MRI also helps us in showing what is the size of the tumor and what can we expect and how much the narrowing has happened. Accordingly, we can plan the surgery also and the anesthetic management. And indirect laryngoscopy I already told you, and the bronchoscopy shows us the dynamic obstruction, how it is happening. So we can always document that, and we can see how narrow it has become. And in the ultrasound, as I already told you, sorry about the picture not being so clear, we can see how much distortion has happened to the tracheal lumen. So we can, from that, assess the patient. And the hyperoptic scopy picture is showing how the anatomy is distorted, how lateral the tube is going, because the swelling is pushing the airway. So how will you prepare them? We have done all these investigations. So it's an interdisciplinary team process. Arna ma'am was also talking about that. Consider the comorbid diseases and treat them, optimize the patient, and when you plan how to secure the airway, please discuss this with the surgeons and also explain everything to the patient and get a patient consent, because patient has to know what can happen and whether he'll be needing elective post-op ventilation or whether he'll have a tracheostomy. So it's always better to explain everything and get the team ready and optimize the patient. So this is what we should do. Always remember, it's a difficult intubation situation. Maybe emergency tracheostomy might be needed, and so the plan will be awake fiber optic intubation. Very rarely we might do give an induction and then try to see whether we are able to ventilate and whether we will be able to intubate, then we can do that. And always explain consequences of hypoxia and cardiovascular complications that may happen on induction and the elective post-op plan. And always keep a plan B ready. Okay, what may happen? So always keep a plan B ready. And how will you manage? So on the day of surgery, pre-medication with proton pump inhibitors, anxiolytics, glycopyrrolate and steroids. Steroids are very good drugs which will be continued in the perioperative period for 72 hours, because with such a huge swelling surgery, you are going to expect some amount of edema. So steroids and adrenal nebulization are two things which are definitely going to help in these patients. Please remember that. And I have put here, avoid sedatives, because if you are going to sedate the patient too much, maybe the airway collapse may happen, or you may not be, if you land up in a situation where you are not able to intubate, you may land up in a patient who is sedated and you will be worried about saturation and all. Then regarding IV lines, 2 wide bore IV cannulas, of course arterial line and femoral venous cannulation if patient need to go on CPB. And there is nothing wrong in having an arterial line, because it's a major surgery, you would want to see the intra-arterial pressure and maintain intraoperative blood loss and fluid management. Pre-oxygenation for 3 minutes is essential and mandatory, and all the monitors, ECG, NIBP, end-tidal carbon dioxide, pulse oximetry and temperature monitoring, you all know it's very important. And the airway preparation for the fiber optic intubation, very, very important, because you will not be able to give the nerve blocks here. So maybe only prepare the nose, prepare the, with the nasal pack, prepare the throat, but then you have to do it with the spray as you go technique for the intubation. So you should have explained it very clearly to the patient. And induction, as you know, intravenous induction is better. Inhalation induction takes time, and the timing of laryngoscopy is going to be very, very crucial. So intravenous induction is better, like that is after you put the tube by awake fiber optic intubation, and use flexometallic ET tubes or microlaryngeal ET tubes. I put the pictures here, and we all know that the special ET tubes are available, which are nerve integrity monitor tubes. I have not seen one, or I have not used one, so I don't have a personal experience of using it, but it has got 2 surface electrodes, and 2 electrodes are there on the endotracheal tube. So when after you put the tube, it's connected and the electromyography is recorded, and if the surgeon is going near the nerve, they're going to know it. So to avoid the injury to the vocal cords. Analgesic, opioid like fentanyl, thoracic epidural and cervical epidural analgesia have been described, and people are using it. Muscle relaxant vecuronium, and with the isoflurane is the ideal choice of volatile agent, and with a closed circuit. So the good analgesia and deeper planes when they are going to do a sternotomy. Please remember that. And IV fluids and blood transfusion according to the need to be given. So now this much we have conducted, but prior to extubation, very, very important here. One thing is it's a huge goiter which has been pressing on the retrosternal region. So you can expect some amount of tracheomalacia. The other thing is vocal cord injury. One more thing is hematoma, because it's a huge swelling and so much surgery has been done. And then the other thing is edema. These 4 things we have to really be prepared to manage the patients. Let's see what all we should do. That's when I said about adrenaline nebulization and steroid, 1 dose of steroid before extubation, and continue it for 48 to 72 hours mandatory. So first thing is nerve injury. As I said, we can use it nerve integrity monitoring endotracheal tube if it is available, so we will know intraoperative itself. But in the postoperative period, it's always better to extubate while you do a fiber optic scopy or a video assisted laryngoscopy. Document the vocal cord movements. Okay, if there is any one side nerve injury, it is an odd movement is not there, maybe you can discuss with the surgeon. They may plan for extubation and reassess the patient, or we can go for keep the tube for 48 hours and then reassess. Very rarely you might land up in a situation where elective tracheostomy has to be done on the table. So here this algorithm just is generally for a major neck and upper airway surgery, but what you can see is if there is a hematoma, generally intraoperatively, immediate post-op we don't make it out, but once patient is shifted to the ward, they made out, and it has caused lot of issues. So that's why you got to be very, very careful. Even little bit of swelling, it's better to observe the patient on table before extubation. And the other thing what is shown here is depending on your cuff leak and how do you do your find out about the tracheomalacia. Here tracheomalacia, as I think all the postgraduates are aware that we do a cuff leak test prior to extubation. So we can either assess, auscultate and see whether audible leak is there, or now that we connect the tube to the ventilator, so we can measure how much is the volume. Suppose the leak is less than 110 ml or the audible leak is not so good. It's always better not to extubate, keep the tube on, keep it for 48 hours and then reassess. Very rarely, as shown here in the algorithm, here they are saying, this I took from the Anesthesiology News 2021, here they are saying if you think the cuff leak is all right, it's in the borderline, maybe you can extubate, observe, but keep intubation ready and then give nebulization, give the steroids, and immediate intubation should be ready. And what is tracheomalacia? So long I have been saying cuff leak test and tracheomalacia. So that's why I said when you extubate, we should put the fiber optic scope or a video laryngoscope and observe. So when you put a fiber optic scope, you are going to see the tracheal walls collapsing. That's what is shown here in these. In such patients, elective post-op ventilation for 24 hours, reassess and trial extubation. That's what we do in our hospital. On-table elective tracheostomy very rarely may be needed, and then reassess the patient after 48 hours. The X-ray is showing how there is narrowing and there is approximation of the tracheal mucosa. So in a huge thyroid swelling with a retrosternal extension, what are all the take-home message? See, it is posing a unique challenge of difficult and shared airway, possibility of airway compromise perioperatively, and complication. So it is a teamwork, multidisciplinary, plan your airway management correctly, discuss it with the patient, and awake fiber optic intubation is what is advised. But please remember, you have to keep smaller tubes, because the narrowing may be, it may pass below, it may be able to pass below the vocal cords, but it may be lower down. So remember that. And the second thing is the perioperative and postoperative complications of tracheomalacia, edema, and blood loss, along with nerve injury. So with all this, if you plan, and all the things are planned with the patient and also with the surgeon, because postoperatively, in case the patient needs tracheostomy for a tracheomalacia or the nerve injury is there, you are going to keep a tube. And if elective ventilation is needed, also intensivists should be involved, and then that is how we are going to get a good outcome. So these are some of the references. Most of these things are given in our anesthesia textbook itself. I did get some references from studies of retrospective case analysis or case reports, and every hospital, I am sure, would have managed one particular patient, how they have managed. If I think our senior consultants, so many of them are here, they would have managed differently. I would like to take from their experience, and these are the references. Thank you all.